So in this short lecture, we're just going to look at vertigo and dizziness. These are really common complaints that people have coming into the office, and it's good to know what are the most common causes of vertigo and dizziness. How do you differentiate actually vertigo from dizziness, and then how do we think about their workup? So a lot of people say vertigo and dizziness kind of as, they kind of equate the two. But they're actually a little bit different. So there are three major causes. Let's just stick with dizziness, and that's the sense of just kind of, I feel dizzy, my head's kind of spinning. So pre-syncope, this would be like you're about to pass out. That's lightheadedness. And so that's when the patient like stands up and they feel lightheaded and so forth. So some patients will say that's dizziness for them. And that can be a variety of causes, the most common being either metabolic or cardiovascular. Their blood pressure is too low. More ominously, they could have something like heart failure or something like that, but typically it's like low blood pressure, maybe they're dehydrated, they have low blood sugar, things like that. So that's lightheadedness. And we, in the history, can kind of glean that just by asking, when does the lightheadedness occur? What are the factors that kind of leads to that? Next would be vertigo, and that's a sensation of spinning or hallucination of movement. So they sit down and like the room is spinning around them. That's vertigo. And there are two types of vertigo. Central vertigo is a problem in the brain, usually brainstem. Could also be cardiovascular. This is more serious. And then peripheral vertigo usually has to do with the vestibular system in the inner ear. So that's your balance system in your inner ear, and that's usually benign, but certainly not pleasant to have this vertigo because that often triggers nausea. And then another cause of dizziness would be just multisensory stimuli. Often occurs with profound shock or sensory overload. You hear some bad news, you're standing up on a mountain, you get dizzy quickly. So that's going to be less common. So most of our cases in the clinic are either lightheadedness or vertigo. And so in the history, you want to differentiate those two first. Now, I'm going to talk about vertigo here specifically because those are the more concerning things to be able to recognize and rule out maybe potential adverse factors. But the first and probably the most common cause of vertigo is known as Bppv, benign paroxysmal positional vertigo. And this is caused by there being in the vestibular system, there are these little calcium crystals that can accumulate, and they're called otoliths. And what I don't have a picture here, but in your semicircular canals, and you can see them, they're kind of just drawn here, they're found in the inner ear. And so we have the three canals, actually one going in each plane. And so that's going to give you a three-dimensional kind of map. Inside these canals there's a fluid. And then there are little hairs, and each hair is connected to a nerve. So as you move your head and move the body, the fluid moves around, and the hairs are able to detect that fluid movement, and that sends nerve impulses to the brainstem via the cranial nerve number 8. And that is going to be integrated with your balance systems to give you positional balance. So the fluid there is very important for that. Now, as we get older, we can develop these little calcium deposits in there, and they're called otoliths. And unfortunately, what happens is the calcium deposit can fall on one of those hairs and cause it to continually fire. And so it confuses the brain. The brain thinks you're actually in one position when you're not, and that triggers vertigo. So that is the main issue here is the otoliths. 95% of the otoliths are more in the posterior. The posterior canal, and that's shown right here in the picture, and then the other 5% are in the horizontal canal here. So the diagnosis is something called Dix-Hallpike maneuver. So the patient turns their head, his or her head, 45 degrees, right or left, and they go from a sitting to a supine position while quickly turning the head to the other side. So here you see the person here, and they're turning their head, they're going to move down, and they're going to turn the head quickly to the other side. And if that triggers the vertigo, and if the patient shows nystagmus, in other words, their eye starts beating back and forth towards the affected shoulder, where the side of the ear where that otolith is found, that's a confirmation for Bppv. So there's a quick procedure in office we can use to diagnose that. The treatment then is something called the Epley Maneuver. In Epley, it's kind of like a reverse Dix-Hallpike. You do a 270-degree head rotation from the Dix-Hallpike position, and then you kind of move the head back and forth. So that actually can dislodge the otolith. And so that's Epley Maneuver. And usually it resolves cases in about 80% of the time. Sometimes, and a lot of times, these cases actually will spontaneously resolve, so patients will just be out doing something and that'll dislodge the otolith. But a lot of those will occur because that otolith is still there. But the Epley procedure is very simple, very easy. It's hard to see how to do it in these pictures. You might want to just go online, just do a quick Google search. You'll see Epley Maneuver. You can teach your patients to do it. So I have some patients that they do it, it resolves their otolith, it resolves their vertigo, and then they might get it again, and then they know actually how to do the procedure at home, and that usually takes care of it. Usually anti-vertigo medications are contraindicated. That can actually lead to chronic balance problems and so forth. It was thought that maybe removing some fluid from the body through diuretics, so like diuretic herbs and so forth, can help. But typically it's a matter of just moving this otolith, and so Epley is a very helpful procedure there. So that's one cause of vertigo. Another would be acute peripheral vestibulopathy, also known as labyrinthitis or vestibular neuritis. And the patients usually present with acute onset vertigo, just complete intolerance to moving their head. They get really nauseous and vertigo from that. And then there's gait unsteadiness. And so nausea, vomiting, nystagmus are all pretty common findings with acute peripheral vestibulopathy. Labyrinthitis is usually, what that is inflammation, usually from an infection, a viral infection of the labyrinth, which is all the semicircular canals. And that includes unilateral tinnitus, so ringing in that ear fullness, and maybe even hearing loss in that ear as well, because the cochlea is right next to all of this. If there's no auditory symptoms, then we say the diagnosis is vestibular neuritis. So that's a inflammation of the vestibular nerve. Again, usually from a virus, we think. Now, importantly here, a patient can have a stroke in the lateral pons or in the cerebellum, and that can actually mimic labyrinthitis. As well as in the lateral medulla or the cerebellum, that can mimic vestibular neuritis. So again, the difference with labyrinthitis is we need the hearing loss with that, and the tinnitus with the vertigo, versus with the neuritis, there doesn't have to be any hearing loss or tinnitus. It could just be the vertigo. But the strokes can actually mimic that. So that's something, especially in maybe an elderly patient who maybe is more prone to strokes. They might have a history of stroke. They suddenly develop vertigo. That's probably not from the virus. That might be a stroke. And so they need to be referred for imaging to see if that's actually what's happened, and that needs to be dealt with from there. So the diagnosis is one of exclusion, basically, but the first thing we always do is rule out stroke. So we're going to consider that in our high-risk patients. And that would be, with increased age, one or more of the stroke risk factors we've already talked about, and then potentially using MRI to diagnose any potential lesions that have occurred from a stroke. So once we are satisfied that this is not due to a stroke, then the treatment would be typically biomedically giving acute doses of steroids within the first 72 hours of symptom onset, and then potentially anti-vertigo medications like meclizine. That said, on its own, it typically resolves within a couple of weeks. It can take a couple of months, and it's unpleasant for people to have that vertigo for a couple of months. But vestibular neuritis and or labyrinthitis, pretty common. I see a lot of patients with this. They think they have Bppv, but it's actually due to this. From a more integrated perspective, again, supporting kidney metabolism, our kidney Chi tonics actually increase endogenous steroids, and those actually can potentially be helpful for reducing the inflammation in the inner ear that's occurring from this. So that would be one potential approach. So that's acute peripheral vestibulopathy. Now, a third cause of vertigo would be Meniere's disease, and this is recurrent vertigo with auditory symptoms. It affects at least 1 in 500 in the US, and it's more common in females, so fairly common. Presentation is recurrent episodes with severe vertigo. hearing loss, tinnitus, and ear fullness, and it often lasts for hours to days. Nausea and vomiting are common here, and there's a loss of low-frequency hearing over the years, so there's going to be deafness on the affected side. That's Meniere's disease. The diagnosis is usually made clinically through history and physical. We rule out other factors like transient ischemic attacks or stroke. And the patients have to meet the following criteria. So you have to have 2 episodes lasting greater than 20 minutes with remission of symptoms between the episodes. So they get vertigo with the auditory symptoms for more than 20 minutes. And then hearing loss documented at least once with audiometry. So over time seeing a gradual decline in hearing loss. And then the tinnitus, patients have to have that as well, the tinnitus and oral fullness. So the approach is, of course, addressing levels 1 through 3. The biomedical approach, the old approach, used to be getting fluid out of the body, so low sodium diets and diuretics. The new approach is usually trying to use anti-inflammatory diets, different lifestyle changes to reduce inflammation, like reducing drinking and smoking, using prophylactic migraine medications, the triptans, and then antiemetics. Those are medications that block vomiting, like the Zofran and whatnot. And then rarely benzodiazepines are used here. In severe cases, there can be ablation to the nerve there, and that can result in remission. But of course, you'd probably have permanent hearing loss at that point. So this is kind of the general approach to Meniere's, but that would be a third cause of chronic vertigo in patients. And then finally, we should mention vestibular migraine. This is a cause of recurrent vertigo with no auditory symptoms. Affects about 10% of all migraine patients. So patients usually have a history of migraine. There are recurrent episodes of mild dizziness to severe vertigo lasting minutes to days. There's usually nausea, vomiting, photophobia, that's light sensitivity, and then headache is usually mild to severe. So here we have the vertigo with a headache with no auditory symptoms. Balance, however, can deteriorate over the decades. So we think this inflammatory process eventually affects the balance system in your inner ear. So the diagnosis is usually made clinically with history and physical exam. After ruling out other factors, TIAs, vertebral artery dissection, etc., we basically call this a diagnosis of exclusion. So again, this is similar to patients with the Meniere's, but without the auditory symptoms and so forth. So patients with Meniere's without auditory symptoms and documented hearing loss, typically now we say they have vestibular migraine, not Meniere's. In imaging, brain MRI is, of course, going to be indicated if we suspect other causes like stroke or tumor, vestibular schwannoma, etc. The treatment would be, again, levels 1 through 3, kind of our typical migraine treatments, and pharmacotherapy would be the same as migraine, triptan drugs, and so forth. So those would be the most common causes of vertigo. And I put a section in here because, again, this is pretty common for patients to come in complaining of vertigo. And again, the first thing to differentiate is really, are they having vertigo or just dizziness? And if it's dizziness, I didn't speak about that here, but that's where we need to really, like lightheadedness. You get lightheaded on standing. That's when we got to do more testing, like check their blood pressures, check what's called orthostatic blood pressures, so you have them lie down and then have them stand up, and then take their blood pressure in both instances and see what the difference is between standing and lying down, and that can tell you if the autonomic nervous system is really compensating appropriately. There could be hypoglycemic issues, but again, more ominously, there could be cardiac issues. So for someone with persistent lightheadedness, that's again something that needs to be fully worked up by their primary care physician, maybe with appropriate referrals. Okay, so that's it for dizziness and vertigo.